So when a person comes to your office and they're complaining of hip pain, what is, the most, I don't know, call it the three most likely sources of that pain? And obviously we'll go through some of the examination so people can sort of see how you will
Sure,
go about gathering that information.
sure.
But what would be the top three most common diagnoses you'll encounter for a
Right.
person with hip pain? And let's maybe bracket this by saying a person under 50.
Okay, sure. So, someone comes in with hip pain. Right away, I'm sort of thinking about the different layers of the hip. So in my mind, I'm thinking, is this a bone problem? Is it a bone cartilage problem? Is it a connective tissue problem? That is a ligament problem? Is it something? Is the capsule too loose? Because the ball is held in the socket by a capsular layer. Or is it a muscle and tendon problem? So we from deep to superficial, we have bone, cartilage, and then we have connective tissue, ligaments, capsule, and then we have muscle, tendon. And then we also have to recognize that sometimes hip pain is referred pain. That is, it could be coming from your back. So we're thinking about those separate layers. And then we're also thinking about location. So someone who has pain in the front of the knee, the front of the hip is different than someone side of the hip, back of the hip. So we need to tease all those factors out. So someone under the age of 50, would not necessarily be thinking about arthritis, but it obviously is always on your mind. And finding out a clue to what the diagnosis often depends on when it hurts, where it hurts, and what their activity is. So, for example, um, I think about patients, they come in, they say, we have the endurance athlete, we have the power athlete, we have
The non-athlete,
the
presumably, yeah.
non-athlete, the the individual who is flexible, gymnasts, ballet dancers. They sort of have different patterns of hip problems. If we start with the endurance athlete, let's start there. Endurance athletes, is we start deep down in the joint. The first thing we have to rule out is that this is not a stress fracture. Stress fractures can happen in a lot of different areas in the lower extremity, and we separate them out as to high risk stress fractures and low risk stress fractures.
Risk of bad consequence if not treated.
Correct. So if someone comes in and they have a marathon coming up and they say my hip hurts, we have to make sure that this is not a stress fracture. Femoral neck stress fractures.
So just differentiate a stress fracture from a fracture.
Sure. So a stress fracture is something that occurs slowly. So a stress fracture at baseline, potentially normal bone with a substantial load to that bone that is in excess of what the normal healing capacity is of that bone. That is, bone constantly remodels. Every time we put stress on it, the microarchitecture is changing. There's small, tiny microfractures that occur from normal weight bearing. The body is very capable of adjusting to that load and making new bone. When you start exercising or working out or running, the bone will get stronger based on the stresses that that bone sees. So for runners, for example, if you are training properly, there's no reason to expect that that bone can't adjust to the increased load that it's seeing. But oftentimes, due to overtraining, where you're not giving that bone enough of a chance to
Mm.
heal, you develop these tiny little microfractures that aren't given enough time to then heal, and then it gets compounded when you go run the next day and the next day, and you're increasing not only the number of times that you run, but you're increasing the distance and the speed all at the same time. You get groin pain, because that's where stress fractures of the femoral neck hurt. Right away we know we need to rule it out. And they tend to occur in the femoral neck, and we have two locations. Either this is called the compression side and this is called the tension side of the neck. And tension-sided fractures, where you get a little crack in the bone here, are much more severe than compression side. But the bottom line is that we need to know that this exists.
And the patient will feel groin pain, which is otherwise difficult for them to differentiate. I mean, they're not going to come in and say, my femoral neck hurts.
Correct.
It's what is the actual feeling? Does it feel akin to what you would feel if you pulled a muscle in your groin?
It does, except it's very weight-bearing dependent.
Mm.
So most people who come and say, I think I tore a muscle, I think I have a muscle strain. I don't see a lot of muscle strains in runners without an injury, right? You run, you're training, you're not necessarily going to get an acute injury like that. So sort of the presentation's slightly different. But it hurts in the groin, and right away you don't let them run until you find out if it's a stress fracture. And here's why.
And sorry, the MRI is the gold standard?
It is. So x-rays, we always need to get x-rays to make sure you're making sure that the joint looks healthy. There are other conditions that can cause groin pain, but it's usually negative. It's usually hard to detect a stress fracture right when the pain starts. The MRI is the gold standard to see that. It used to be bone scan, but that is impractical. And an MRI really is excellent at looking, because you can see the architecture of the bone, and you can see basically what we call edema in the bone, or a bone marrow lesion, and sometimes a crack in the bone. And it's graded. There's stress reactions, and then there's stress fracture. A stress reaction is like a pre-stress fracture. And the reason why it's a high risk stress fracture as opposed to a low risk is if it becomes a complete fracture, which was the other part of your question, what's a complete fracture? It's where this completely separates from the ball. And that's very important in this area because the blood supply to the head comes from this direction. So all of the nutrients that the ball sees comes from this direction. If this breaks and the blood supply is disrupted and that's not corrected quickly, then the bone in that area no longer has blood supply. It will die and can't support the cartilage anymore. The cartilage will
Vascular
collapse
necrosis.
and you get AVN of the head, and that is a hip replacement, which is obviously difficult for anybody, but for someone who's in their 20s, 30s, 40s,
So the treatment for this when you make the diagnosis is rest.
is rest, typically. So if it's on the compression side, this is the compression side, you can go on crutches until you start to have no pain with weight bearing. Once you have no pain with weight bearing, you can continue along that path. Takes 6 to 8 weeks to heal, and then you can slowly start up your exercises to regain some of your endurance, physical therapy, etc. And oftentimes I'll get a follow-up MRI to make sure that it is healing and not increasing. If the stress fracture is on the tension side, the other, because you can imagine if it starts to crack on this side and the whole weight of your body is coming down this way, it can more likely displace mechanically. That often will need to get surgery, which is to put pins in, and we will often just put 3 pins from here to here into the femoral head, and it will heal, and they heal quickly. And oftentimes you can let that individual bear weight sooner.
So paradoxically, the riskier stress fracture usually has the quicker recovery because they go to surgery as opposed to...
The tension-sided stress fracture, it just means you can often end up getting walking around doing what you need to do in your normal life too. I've had patients with compression-sided stress fractures who are having so much difficulty with just their getting onto the subway, getting to work with the crutches, that they wanted to have the surgery so that they can do that.